Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist, and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mamounis, our breast surgical oncologist.
This is Terry Mamounis. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mamounis. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. Our next case is a 74-year-old with a more extensive clinical stage 3 breast cancer. It's a multicentric invasive ductal carcinoma of the right breast. Her disease is ER positive, PR positive, and HER2/neu positive. PD-L1 is unknown. She was treated with a neoadjuvant chemotherapy approach and subsequently had a mastectomy and axillary lymph node dissection. She was found to have residual disease subsequent to her neoadjuvant chemotherapy. And one of the major questions for the panel is which systemic treatment should the patient receive next? So a little bit about her history. She noticed an enlarging right breast mass and did not immediately seek medical attention. She has an excellent performance status and no major medical conditions. She has no family history of breast cancer or other oncology malignancies. Her mammogram and ultrasound we're not going to be reviewing today, but they reviewed a 2.4 spiculated mass with calcifications in the lower outer quadrant of the right breast. She did have enlarged bilateral axillary lymph nodes. We see here a PET-CT scan, and it does show a lower outer quadrant lesion in the right breast, and I think we'll be able to point out an axillary adenopathy as well. She was staged with an MRI of the brain, which was negative. Dr. Butler, do you want to comment on this single PET-CT that we show here in this slide?
Sure. We see a few slices here of the PET-CT scan. And I'll just mention that this is a study that's done with a radiotracer known as fluorodeoxyglucose, which is an indicator of metabolic activity. And the abnormal metabolic activity that we see in these slices is in the right breast, in the top two, and in the right axilla, where it's particularly FDG avid or bright, indicating that she has multicentric disease of the right breast with right axillary adenopathy.
Do you recommend a PET-CT as kind of a standard staging for anybody who has, in this case, stage 3 disease? I'm not quite sure why she's called stage 3 disease with a 2.5. Sounds as if it's a T2N1 disease, but even in lymph node positive disease, do you recommend PET-CT as a form of staging?
PET-CT is one of our, I think, most reliable ways to stage for breast cancer when metastatic workup is indicated. Oftentimes, we'll pair a PET-CT scan with a bone scan, which can complement our evaluation for bone metastases.
Okay, thank you. And MRI of the brain, is that a typical component of staging studies?
It's not a routine component in our practice, but certainly if the patient has any neurological symptoms and there's concern for metastases to the brain, it's the ideal modality to search for that.
Okay, thank you. So the patient did undergo core biopsies of the right upper outer quadrant and lower outer quadrant masses. And in addition, had fine needle aspiration of the bilateral axillary lymph nodes. The pathology is shown here on this slide, in the upper outer quadrant, she had an invasive ductal carcinoma grade 2. Her disease was ER positive at 95%. HER2 FISH positive with a ratio of 6.3 on FISH and a Ki67 of 10%. In the same breast, a separate biopsy, again showing multicentric disease, again ER positive, FISH positive, HER2, and a little bit higher Ki67 at 20%. The FNA of the right axillary lymph node was positive for metastatic carcinoma. As mentioned, she had some vague ultrasound appearance of a left axillary lymph node, which also was biopsied and negative. So again, she has a multicentric ER positive, HER2 positive. She went on to receive neoadjuvant chemotherapy. Dr. O'Shaughnessy, would this be your approach for someone with either advanced stage 2 disease or stage 3 disease that is HER2 positive? Can you comment if you would likewise recommend chemotherapy as an initial approach?
Yes, yeah, we always recommend preoperative chemotherapy, trastuzumab and pertuumab, and do favor the docetaxel, carboplatin, trastuzumab, and pertuumab regimen. We really want to know if patients have a pathologic complete response or not, because we do offer adjuvant TDM1 for patients who don't have a pathological complete response. And also there's got to be consideration of neratinib in patients who still have considerable disease that's ER positive after preoperative therapy. The TRAIN-2 study recently showed in the preoperative setting that a TCHP regimen as here was equivalent to an anthracycline followed by THP regimen in stage 2-3 breast cancer with regard to both pathological complete response rates as well as invasive disease-free survival. So that was really quite persuasive that I don't really see the need any longer for an anthracycline for HER2 positive breast cancer. So yes, I would totally agree with this strategy here.
Fantastic. I guess Dr. Mamounis, the fact that she has clearly multicentric disease in 2 distinct quadrants of the breast makes breast conservation a little bit more challenging. And as noted here, she went on to have a right mastectomy and an axillary lymph node dissection. As you're approaching a patient like this, subsequent to her chemotherapy, I think Dr. O'Shaughnessy would predict an excellent chance of having an outstanding clinical response. If the lymph nodes become negative on re-imaging, what would be your approach of management of the axilla, let's say?
Yeah, so the management of the axilla has become also an important component of our treatment with neoadjuvant chemotherapy. I mean, traditionally we use neoadjuvant chemotherapy to downstage the disease in the breast and maybe convert the mastectomy candidate to lumpectomy candidate. But then we realized with a higher rate of pathological complete response and the availability of sentinel lymph node biopsy as an option to stage the axilla, the potentially exists to actually downstage the disease in the axilla and offer the patient limited axillary surgery with the incorporation of sentinel lymph node biopsy. And clearly for patients that present with clinically negative axilla, that has been sort of the standard now to offer the sentinel lymph node biopsy afterwards, which appears to be as efficacious and as accurate as in the upfront setting. For patients, though, who present with positive lymph nodes documented by biopsy, then we have to be a little bit more careful because studies of sentinel lymph node biopsy after neoadjuvant chemotherapy have shown that the false negative rates were a little higher, in the mid-teens, 12 to 14%. However, more recently, the incorporation of biopsying the node in the axilla, introducing a clip in the lymph node, and then being able to localize this clip and remove it afterwards, along with performing a sentinel lymph node biopsy, what we now call, the coined term by MD Anderson is the targeted axillary dissection, is something that has shown us very, very low false negative rates and very much accuracy of determining if there is residual disease in the axilla. Obviously, if there is residual disease, then the standard would be to perform an axillary dissection, such as, for example, in this patient who had 1 out of 7 axillary lymph nodes. But if they sentinel lymph nodes and the targeted lymph node are negative, then it's only about 2 to 3% false negative rate. So for those patients, we actually do not favor completing the axillary dissection at this point. There's some debate on that, but in general, I think we're leaning more towards not doing a completion axillary dissection for these patients to minimize the morbidity.
So when you do an axillary dissection in the setting of neoadjuvant chemotherapy, here we have 7 lymph nodes recovered, one of which was positive. Do you often see fewer lymph nodes recovered after neoadjuvant versus doing an axillary dissection up front? Are you concerned that maybe she didn't have a complete level 1-2 dissection with 7 lymph nodes?
So that's a complicated sort of question, because literature suggests that indeed after neoadjuvant chemotherapy, you tend to recover less lymph nodes than up front. Now, some of it may be lymph nodes that were involved and then they become negative and they're scarred, so they're not being identified. But some of them may be sort of the pathology technique and as well as the surgical technique of identifying lymph nodes. All these are factors that predict how many lymph nodes are removed. But if somebody performs what we call a standard level 1 and 2 axillary dissection, described in the operative report as identifying the landmarks for an axillary dissection, then I would accept those findings and obviously don't have to go back and do more. But sometimes if it's a very limited dissection, one can make the argument if only a few nodes have been removed.
Okay. So as noted here, the pathology indicates residual disease in both of the quadrants of the breast. Fortunately, it's a very small amount of residual disease at 1 millimeter and 2 millimeters respectively. The surgical margins were negative. There was a 0.6 metastatic focus in 1 out of 7 lymph nodes, and so appropriately was pathologically staged as a YP T1, YP N1 disease. So as we're considering next steps, what would be, first from our radiation oncologist, Dr. Shaw, your recommendation with respect to consideration of, does she need post-mastectomy radiation? Would you recommend it? What would be the target? What would be the fractionation schedule you would recommend?
So in a 74-year-old with residual nodal disease post-neoadjuvant chemotherapy, we would recommend post-mastectomy radiation. In terms of the targets, that would include the chest wall, the supraclavicular fossa, and the internal mammary nodes, as well as the axilla. There is some controversy regarding blocking the dissected axilla versus covering the whole axilla. And in a patient with 1 lymph node without extracapsular extension, it could be considered to block out the dissected axilla in this case and only treat the undissected axilla, the internal mammary nodes, and the supraclavicular fossa along with the chest wall. In terms of radiation, even though this is a right-sided case, we would still consider using some cardiopulmonary sparing techniques, particularly given that she's 74, to do that, particularly when treating the internal mammary nodes. In terms of dose and fractionation, the standard is still 50 gray and 25 fractions. However, if she had chosen a mastectomy without reconstruction, we would offer her a hypofractionated course of 40 gray and 15 fractions based on the Chinese randomized trial that was published.
Dr. O'Shaughnessy, with respect to systemic treatments for this patient, again, this is someone who has residual disease subsequent to TCHP neoadjuvant treatment. First question would be, do you ever do biomarkers? Are they necessary on the residual disease, or are you treating on the basis of the upfront biomarkers?
It's not necessary in this particular case to do biomarkers on the residual disease, because I'm going to treat her with endocrine therapy based on her original estrogen receptor positive breast cancer. And regardless of whether HER2 is positive or negative on the residual disease, the Catherine study has shown substantial benefit from adjuvant TDM1. Some very nice work recently showing that even if the residual breast cancer is HER2 negative, patients still benefit from TDM1. So the standard would be 14 cycles of TDM1, and it can be given along with the radiation therapy and along with endocrine therapy, which would be a aromatase inhibitor in this patient. We would also treat her with IV zoledronic acid twice a year for 3 to 5 years, per the national and international guidelines, to reduce her risk of bone recurrence, as well as reduce the risk of osteoporotic fractures. The other thing is that when she finished her TDM1, and I would tell her about this in advance, because you really have to tell people in advance if you're going to be thinking about neratinib for them down the road, that I would talk to her about neratinib, because we only have, for the Catherine trial, we only have 3-year follow-up, the TDM1 versus continuing trastuzumab, and there was a very substantial 11% improvement in invasive disease-free survival, but it's only out to 3 years. And at 3 years, even those with TDM1 had a 12% risk of having an invasive recurrence. So I think that that's going to get larger as we get out to 5, 8, 10 years, particularly in ER-positive disease, where patients continue to recur for up to 20 plus years. So I would talk to her about neratinib. It is a consideration on the NCCN guidelines because it hasn't been studied in the adjuvant setting specifically after pertuumab and TDM1. In the metastatic setting, it is non-cross resistant with pertuumab and TDM1. And so there recently in the Extenet study, there was a survival advantage in patients who had preoperative trastuzumab and chemotherapy, finished their year of trastuzumab, and then went on to endocrine therapy plus neratinib, and there was a survival advantage in these ER-positive patients. So I would go over that with the patient, because there's very good synergy with blocking the HER family with neratinib and blocking the estrogen receptor. And now we can escalate the dose of the neratinib, start low at 120 or 160 milligrams, and then escalate it up as tolerated. And it's just 1 year of therapy. So I do talk to patients about that. And I've had a number of older women choose that. They want every possibility of remaining cancer-free.
Is there any role for additional chemotherapy? You mentioned she hasn't received anthracyclines. Some people use Xeloda in the setting of post-neoadjuvant chemotherapy residual disease.
There really isn't. The TRAIN-2 data did look at the addition of 3 cycles of an anthracycline regimen before a TCHP-like regimen. There was no advantage in terms of systemic recurrence. So I wouldn't really think that she would benefit additionally from the AC. But for sure, TDM1 has a very marked improvement. The capecitabine has not been really studied in the HER2 positive patients, but again, between excellent endocrine therapy, node positive patients get 10 years of endocrine therapy. Zoledronic acid will reduce the risk of recurrence and death. The neratinib might improve the risk of recurrence and death, and I suspect it will. That's my feeling based on the metastatic data and the extent of non-cross resistance. So she really should have an excellent outcome.
And finally, if this case were a little different, let's say it was a premenopausal 42-year-old with this same residual disease, and you're considering your outback endocrine therapy options, what would be your recommendation? Would you go for tamoxifen, or would you think ovarian ablation and aromatase inhibitor is more appropriate?
With regard to which of the 3 endocrine therapies that we have as options for premenopausal patients is the best fit for individual women, there's tamoxifen, there's an LHRH agonist plus tamoxifen, or there's an LHRH agonist plus an aromatase inhibitor. And the SOFT and TEXT trials and the combined analysis of those trials looking at centrally confirmed risk factors, extent of the estrogen receptor, extent of the progesterone receptor, Ki67, grade, age, size of tumor, extent of residual lymph nodes. And there's very, very nice publications by Meredith Regan in the JCO looking at the prognostic impact of each of these factors. And that's really, with upfront surgery, lumpectomy, mastectomy, looking at the upfront cancer. But even for patients with residual disease who are at higher risk, it would be reasonable to look at those. And with a young age of 42 and node positive disease, ERPR positive, relatively highly, she was actually 10%. She wasn't particularly highly proliferative, but this woman would end up on the higher risk side of things. And the higher the risk, looking at those factors, the greater the benefit from LHRH agonist plus an aromatase inhibitor. And I would say to her, I'm going to recommend 10 years of an aromatase inhibitor. So when the dust settles, when things kind of calm down, you may want to consider a BSO, and then you wouldn't have to take the LHRH agonist anymore.
Thank you very much. So in summary, the panel would recommend post-mastectomy radiation now after completion of her healing from her mastectomy, and subsequently recommend systemic treatments consisting of TDM1 in addition to zoledronic acid, and then endocrine therapy with an aromatase inhibitor for the 74-year-old. And also then finally a discussion concerning the positive and negative potential of neratinib would be appropriate.